So we move on to the next talk. I'll be delivering that talk. So I'll be talking on glaucoma medical management failures and way out. Once we diagnose these patients, we start the treatment protocol of the patient. Still, we'll see a lot of failures during the treatment life of patient. So I have no financial interest in any of the product mentioned here. So failure is a part of glaucoma treatment. One need to be very used to of failures. So once the failures occurs, so what we have to do? We have to identify the failure. Then if the failure is pinpointed, then we have to modify the management protocol. And the final aim of the plan of action is to prevent the progression. So the question comes, what is failure? The failure is drug not giving desired result, or your treatment protocol which is not giving your desired result. Progression despite target IOP. So we see a lot of patients who are showing progression despite that target IOP is achieved in these patients. So we have to pinpoint why that is happening. So reason for the medical failures are poor adherence and persistence, ineffective drug, which is not working well in the patient and not giving the desired result, intolerance to the drug, or complications related with the medical treatment. So the patient can have unacceptable IOP. There can be deterioration of visual field, changes can occur, or there can be structural changes like occurrence of hemorrhages on the disc, or the patient can have adverse reactions of the glaucoma medications. Now, why this unacceptable IOP? Lot of physicians are not still using CCT in their routine practice. Now, CCT is very important, and more so when we are treating a case of low tension glaucoma or a case of ocular hypertension. So correct IOP measurement technique has to be employed. We see a lot of patients being treated with a single IOP. The patients are put on treatment protocol. So that need to be rectified. We do use tonometer which are not calibrated, and that is going to give you false kind of IOP. And at the same time, we have to correctly identify the correct diagnosis also. So as mentioned earlier, gonioscopy is vital to identify the open angle and the angle closer. A lot of angle closer patients are being treated as open angle patients, and we see a lot of failure in these patients with the normal medications. We have to also identify primary versus secondary glaucoma. Now, what is adherence and persistence? Adherence is regular and correct administration of the medication. Persistence is period of time when there is a consistent use of the preferred or the prescribed medical regime. So in various studies, it is somewhere around 15 to 58% during the 3 years of initiation of therapy. And why this occurs, why the poor adherence or why the poor persistence occurs is because of acceptance of the diagnosis, unacceptance of the diagnosis, intrusiveness of the treatment, or fatigue of the patient to comply with your treatment regime, which can involve many medications. So multi-dose has to be brought down to the few doses of the medications. Now, what we can do, ascertain whether the measured level of IOP unequivocally increases risk to an unacceptable level for that patient. So we have to identify reasserting the measured IOP. So we have to actually reassure us with the IOP measurement that the IOP measured is the correct one. And when monotherapy fails to attain target IOP, we can do the class switch, or when it does not achieve, but the reduction is more than 15%, we can do the class additions of the patient in the medications. We can also switch from one PG analog to another PG analog. Fixed drug combination plays a great role. If despite maximal medical therapy, IOP is not controlled, think of alternative like lasers or incisional surgery. So the important point is we have to correctly identify the IOP at different time of the day. So diurnal variation or the diurnal control has to be measured. And then we have to identify or choose the drug to actually blunt the peak and troughs. So that is very important. And then we have to build up our treatment protocol for the patient. Now, regarding the adherence and persistence, we have to actually identify these white coat adherence patients. And we have to do a lot of talking to the patient, as mentioned by Dr. Parul. A lot of chair time has to be given to the patient to actually make them understand what is wrong if they don't take medication, what is going to happen. And in a certain amount of certain patients, we have to be very clear in our language that non-adherence to the treatment protocol may land up you into a difficult situation. Coming to the deterioration of the visual function, we have to make sure that the true field progression is there or not. And for that, we have to create a baseline, and over that, we have to identify the progression. Single visual field can't detect the progression. So if we get a poor visual field with few more points which are depressed in the adjoining area, or the few points which are depressed from their earlier position, we have to repeat the visual field to identify whether these field depressions are going to stay there or not. If they stay there, then naturally we have to term these patients as progressing on the visual field analysis. So precautions in the declaring progression is to have a reliable baseline. Change baseline with surgery is done. Suppose if surgery has been done or the treatment protocol has been changed and the patient shows a lot of changes in the visual field, we have to identify and we have to redo the baseline evaluation has to be created to identify the progression. Minimum 2 to 3 fields are required to term these patients as progressive patients. And GPA or VFI can help us in identifying these patients. So once progression of the visual field occurs, we have to revise the target IOP, and then we can add on our treatment protocol, a treatment regime. We can alter the treatment regime by adding medications, or we can add on with few newer therapies like SLT, or incisional therapies, and we have to augment or change the treatment into these patients. The third part is deterioration of the ocular structures that needs a proper evaluation of the patients even during their follow-up visits. So during follow-up visit, we have to keep looking at the disc and the surrounding adjoining area to identify any early signs of changes which can denote the progression. If there are any certain changes like increasing the NRR thinning, with widening of the RNL defect, appearance of disc hemorrhage, which is very important, optic cup enlargement or appearance of enlargement of beta zone, then naturally these patients need to be taken up for the visual field analysis and OCT to identify the progression. And that's why these patients require serial clinical optic disc assessment or the stereo disc photography or SDOCT to identify the changes occurring at the early age. Like in this case, the changes which is occurring here, the hemorrhage which is occurring here will lead to rather rarification of the RNFL in the due course of time, and which will appear in the visual field later on. And so we have to identify these prognosticating point, and we have to modify our treatment protocol based on these changes. Now, use of technology is very important, as mentioned by Dr. Parul. We have to use the technology, but the technology need to be assisted with a proper clinical evaluation. Otherwise, we are bound to miss some of the diagnosis, or we are bound to miss some of the changes which are occurring in the patients. Then there can be severe drug reactions, and that can also lead to patient not complying with the treatment protocol. And these patients need to identify at the early stage of these adverse reactions to modify our treatment protocol. So there can be toxic reaction, there can be dry eye, which is going to be dealt with Dr. Mamta later on. So we have to do the ocular surface rehabilitations, and we have to choose drugs which are non-toxic to the patient, as we are using these medications for a very, very long time. In fact, for lifelong in patients, and more so when the patient is young, we have to use these medications for very long duration. We have to use drugs which are preservative free. So to take home messages, to identify the failure is of paramount importance. We have to keep on searching for failures in our treatment protocol. If patient is not responding to your treatment, or if he's responding still, despite that, if progression is there in the patient visual field or on the OCT, we have to modify the management by switching or adding the anti-glaucoma medications, or we can use lasers or surgical procedures to actually reduce or blunt the changes which are occurring. And finally, we have to reduce the progression. We have to blunt the chances of progressions. And finally, we have to improve the PQLI of the patient, and that is of paramount importance. if we don't look into the patient quality of life, that itself is a kind of failure in treatment of glaucoma patients. Thank you very much.